Morning, everybody.
Good morning.
Good morning. Let me see. We'll have to look at the syllabus and see how many. We have 2 classes for this chapter. 3. We have 1.5. Okay. Okay. All right, so we're going to start chapter 8 today, and we're going to look at some prenatal information first. Here we go. There, that's showing up for you. Okay, good. Great. So we're going to look at a little bit of prenatal information and then go into early childhood growth and development. And we're going to look at also the growth curves across puberty and things like that. So it's a pretty interesting chapter. The reason we start prenatally is that a lot of things happen while that baby is growing. Most of them hopefully are positive, but there are opportunities for some negative things to occur. But we want to understand what a typical picture would be so that, if we're seeing something that's atypical in a young child, we can maybe go, oh, is it to do, perhaps something happened, right? So when we're looking at growth and aging, we have 2 influences. We've obviously got our genetic hardwiring, right? And that information from the sperm and from the egg of the parents, right, dictates a lot of what happens when we look at growth and aging across the lifespan. But we also need to take into account some of these environmental possibilities. So we have some environmental constraints that can also impact growth and aging. So we have some patterns. Now, when we talked about the motor skills in lab, I said that we had universality and variability, if you remember. And we see those same patterns in growth, right? We have universality of growth patterns that hold true for all typically developing humans. So it doesn't matter whether you're born in Australia or Greenland, we would expect a certain pattern to occur. However, we have this very specific individual variation based upon genetics and possibly some environmental influences as well. So if we understand what the typical pattern is, that makes it much easier for us to create plans for people for rehab or for school, PE, or anything like that that are developmentally appropriate given the point in growth that this individual is in, right? So if you work with anyone under the age of 25 or so, then this growth is still occurring in certain systems. And then if you work with people at the other end of the lifespan, then you're going to see some changes in not well, you might see some degeneration in the skeleton, but certainly changes in the muscular system, changes in the nervous system. Okay, so prenatal, right? The very early development that we see in the embryo is all genetically hardwired, right? And so hopefully that is typical normal development, but there could be some inherited problems that create abnormal, atypical development in the embryo. And then we know that because the embryo and the fetus have a window to the outside world via the placenta to mum, then they're also sensitive, once that placenta is in place, for some positive effects via mum or some negative effects via mum. Okay? So, our clump of cells that we have initially is an embryo up until 8 weeks, so 2 months, right? So the first 2 months, what we have, we call an embryo. And the cells are differentiating at a ridiculous rate to start to form specific tissues and organs. So what started out as one cell proliferates very, very, very quickly, all right? So, pardon me. So we can see what are the little limb buds, what are going to become our arms and our legs by around 4 weeks. We can see a heartbeat around 4 weeks in a typical baby. And by 8 weeks, the clump of cells starts to look like something that we go, oh, okay, now it's starting, I can start to see how it's going to become human, right? So this is about 5.5, 6 weeks, and we have a large amount of brain development compared to the rest of the body, right? Here you can see a little arm and paddle hands. Here's a little, what's going to be a leg and paddle feet. This is probably the heart in there. We've got an eye starting, right? But you can see that a large amount of energy and time has gone into creating the brain. And I want to give you 2 terms that are very important, and I can't remember if they're on the PowerPoint, so let me add them here. Okay, the first one is caudal. Okay, and the second one is proximodistal. I can't see the keyboard, so I'm typing in the dark. There we go. All right, and these 2 terms represent our laws of direction. Okay, so our growth laws, our motor developmental laws have these 2 directional rules that they follow. Okay, so cephalocaudal, anything with ceph at the front of it, has to do with the brain. So cephalocaudal means brain down, top to toe. So that slide that I showed you gave you a very good picture of the fact that this embryo is growing top down, right? So that's one rule. And as I said, it also applies to what we see happen with our motor skills, right? The other rule, proximodistal, means from the midline So proximal, close, to distal, further away, right? So you could see that there was more development in the trunk area than there was of the arms and the hands and the legs and the feet, right? So we go from top to bottom and from the middle to the outside, right? And it isn't one or the other, they're interacting and working together, these rules, okay? Okay, so this one is a few days later than the previous picture. And here the embryo is curled up and facing away from how the picture is being taken. So this gives us a good picture of the development of the spinal cord, right? So proximo, middle, you can see there's a lot more development going on in the middle than there is with the arm bud. Okay. Here's the placenta, here's the yolk sac, this is the amniotic sac. Okay. Now the placenta is interesting, it doesn't attach until between weeks 2 and 3. So during the first couple of weeks, that baby has no link to the outside. So there's not any environmental danger to the embryo during the first 2 to 3 weeks. Once the placenta is in place, now it's got this direct link to mum, and so anything that mum kind of experiences, the baby also is going to be experiencing. Okay, this one is 8 weeks. So this is at the transition from embryo to fetus. All right, so it's an embryo to 8 weeks, so this one is just changing over. And the important thing to note on here, hopefully you can see it, it's not too dark, is that at 8 weeks, this baby doesn't have bones per se, right? So the tibia and the fibula in the lower leg here aren't ossified. They're cartilage at this point, okay? And we have what we call the primary ossification centers. So if you look carefully, you can see some dark shadows around the middle of where the bone would be. That primary ossification center is responsible for laying down the minerals that are going to turn the cartilage into solid bone, okay? And if you get to look at it very closely, you can see the same thing is going on in the bones of the feet. So any long bones, the arms, the fingers, the toes, the legs, have these primary ossification centers like this, all right? And as I said, they're responsible for formulating the cartilage into ossified bone, okay? So, 8 weeks transitions from what was an embryo to what is now called a fetus, okay? And we continue to see massive, rapid growth in the fetal period. And growth in body cells occurs 2 ways when we're in the womb, right? We have hyperplasia, so the baby is laying down new cells that's being dictated by its genetics, right? And then we see hypertrophy, which is an increase in the size of the cells that are being laid down, all right? So hyperplasia is an increase in the number of cells. Hypertrophy is an increase in the size of the cells. All right, and that's an important idea because when we get past birth, we don't see a lot of hyperplasia going on, right? So we'll come back to those terms as we're looking at further development. Oh, there we go. There's the reminder of our directional laws. Cephalocaudal, head to toe, proximo-distal, near, midline to far out towards the periphery. So certain cells have a degree of what we call plasticity, and I always struggle with that term because to me, plasticity brings up a picture of something that is rigid and hard, plastic. But actually, what it means when we're looking at growth and development, it means that they're able to be flexible, right? They're genetically driven to be one kind of tissue, but if necessary, they can become something else and take on a different function, right? Some cells are more plastic than others, so the cells in the brain are much more plastic than cells in, let's see, in bone, for example. So if something happens to the brain, then cells can migrate and take on jobs in an area that might have been damaged, for example. All right. Okay, here we have 11 weeks, so we're almost at our first trimester, okay? And again, we've got a nice picture of the idea of cephalocaudal development. Here's the brain, right? Here's the spinal cord, here's its little butt, here's one leg, here's an arm, so you can see that arm bones are developing ahead of the fingers, so that's our proximo-distal rule, and our head is much, much more developed than our digestive system and our legs, okay? So, typically, right, the baby is going to be healthy, it's going to be formed correctly, it's not going to be birthed with any particular problems. Unfortunately, for a small percentage, very small percentage of children, they are born with a genetic congenital abnormality. So that congenital abnormality can be what we call a dominant disorder. So only one parent had to have the bad gene for that particular disorder, or it can be a recessive disorder, which is really unlucky because that means that both parents had the same defective gene. And so when you put those two together, they're strong enough to create the disorder. Okay? That's pretty unlucky for the baby, but it does happen. Okay? Also, we've got extrinsic factors that I mentioned that can affect the baby through either its nourishment from the mum or that the mum is exposed to something that's not healthy in the environment, and so that physical environment can impact the baby via the placenta. And when it's an extrinsic factor like that, we call it a teratogen. Okay? So the effect of the teratogen can be having too much of exposure to that substance. Occasionally, it's a result of too little exposure to a particular substance, but more often there's too much exposure to something that isn't healthy. So this is quite relevant right now at this point in time, right? The placenta is able to act like a gateway almost. It can block some very large viruses, but some viruses aren't that big, right? And so they can get through the gate and be harmful to the baby. So this is quite an interesting discussion right now. I have a friend who is currently pregnant, who works here, and I went and got my first vaccine shot last week. And I called her and said, you know, there's this vaccine available up in Clovis, maybe you should go. And she said, well, I'm not sure what to do because the research isn't clear whether or not it's safe to have the vaccine while you're pregnant. So is that a virus that can cross the placenta or a virus that is going to get blocked by the placenta? And apparently the research is not clear right now. So that's interesting that, you know, here's the vaccine and she's unsure to take it because she doesn't want that baby to get COVID, right? So other environmental variables that can harm the baby, things like temperature. So pregnant women are typically advised not to use a sauna or a hot tub. The x-rays, so if you're at the dentist or if you're in the hospital and you have to have any kind of x-rays, they're always going to check if you're female whether or not there's a possibility that you could be pregnant because the x-rays can reach the fetus. Oxygen deficient atmospheres, so long distance flying, for example, is not recommended at certain points in the pregnancy because they drop the oxygen saturation down in the air in the cabin, right? So that can impact, you know, that oxygen isn't just providing nutrients and the possibility for energy production for mum, also for the baby, okay? Any kind of pollutants, any pressure on the mum's stomach. And so what we're interested in when we're looking at teratogens is at what point in the pregnancy was the mum exposed and for how long, right? Because the tissues and the organs of the baby don't develop at the same rate, right? So we see very rapid development of the brain, and then we see development of the eyes, and we see development of something else, right? It's not all occurring. The baby doesn't grow in one piece, right? So different systems are developing and growing at different times within the pregnancy. So the system that is doing the developing at the point of exposure is the system that could be vulnerable, okay? So I'll come back to that idea in a minute. So this chart gives us some cool info. So you can see here, remember I said that the placenta is not attached until between weeks 2 and 3, okay? So at this point in time, these first couple of weeks, there can't be any teratogenic effect on the embryo, right? And also during this first couple of weeks, this blob of cells is so tiny that often, unless it was a planned pregnancy, often mum doesn't even know, and much more common than we realize is that spontaneous abortion of this embryo occurs very frequently, and often the female just thinks she's having a particularly heavy menstrual cycle or something like that, right? So once we get here though, now the placenta is in place. And so anything that the mum gets, baby gets, all right? So here we have rapid brain development here, all right? Here's the development of the heart, okay? So the darker shading on the bar shows the most vulnerable period for that organ or that tissue. And the paler area of the bar shows it's still vulnerable but less sensitive to a teratogen that might impact it, okay? And then we've got limbs, we've got lips. So if the baby's going to get a cleft lip, it is likely to occur during weeks 5 and 6, and maybe into week 7, right? Once we get to week 9, the lips are formed, and so a cleft lip can't occur, okay? This one is interesting. Here are the ears, okay? So from the middle of week 4 until the middle of week 9, we've got a particularly sensitive period in time where if the mum catches German measles, for example, it's highly likely the baby could be born deaf, right? Or at least poor of hearing, okay? But if mum catches German measles in week 35, the baby isn't going to be born deaf because the ears have finished developing, right? So it's the timing of the exposure and then the amount of exposure that dictates how much damage may or may not be done, okay? There will be a handout. There is a handout on Blackboard. There is a PowerPoint that has heaps of information about teratogens and what effect certain teratogens can have at certain times. So if this is a topic that is of particular interest, you can go and have a look at that. Have a look at that PowerPoint. Okay. So what are some substances that pregnant women are told to avoid? So does anybody know something that if you find out you're pregnant, your doctor's going to go, okay, don't do this?
Wait, can you repeat the question, please?
Sure. So if the woman finds out she's pregnant, what are some substances that the doctor is going to say to stay away from?
Oh, easy. Alcohol, cigarettes.
Yeah, right. Because those can directly impact the development of the baby. All right? Cigarettes block oxygen getting onto the hemoglobin. And so the I think it's the carbon monoxide jumps on the hemoglobin and blocks the receptor site for the oxygen. And so the baby's oxygen levels are dropped down, right, if you're a smoker. Alcohol gets into the bloodstream. If it's in the bloodstream, it's in the baby because the bloodstream and the baby's mum's bloodstream and the baby's bloodstream interact across the placenta, okay? So I think we covered the second point. Substance.
I do have a question.
Sure.
So, teratogen's definition is basically the substances that a woman needs to avoid from?
Typically, yes, although teratogen in its widest form is an external environmental influence. So for example, the next point in some textbooks would be certain prenatal vitamins, for example, that the woman is advised to take to make sure that the baby is getting all the vitamins that it needs. So in certain textbooks, they would call prenatal vitamins a positive teratogen. My training in teratogens is really that they're something that's negative. So in this book, they're a little bit more flexible with their definition of a teratogen. For me, it feels like something that's going to have a bad impact on the baby. But
Well, basically, it's any external influence on the fetus.
yes, yeah.
Okay, cool. Thank you.
Okay? So, let me go back just a minute here. Since you asked that question, Neri, the PowerPoint that is up on Blackboard has a lot more details. For example, about the impact of smoking and the impact of alcohol, the impact of aspirin and over-the-counter drugs, illegal drugs. Alcohol is a biggie. Again, because often, if this is not a planned pregnancy and you are not having safe sex, right? And you get pregnant and you don't know you're pregnant, and then you're partying and drinking, in those early weeks of the pregnancy, that alcohol can really impact the baby's brain development and its facial features. So we get what we call a fetal alcohol syndrome, and you can identify FAS babies and children because they have these kind of flat features in their face, a little bit like a Down's child, but Down's children have usually slightly more structure to their faces, and the fetal alcohol kids will get these extra flaps of skin around their eyes, so they don't look quite right? And then when you watch them move, you know they're not quite right because their movement is very uncoordinated, and they are, well, I've never worked with one that was not motorically delayed. So they certainly are not where they should be for their motor skills for their age. So, as I said, that information is in that other PowerPoint if you want to read some more. Okay, so we get through our 9 months, hopefully 9 months. Hopefully the baby is not early, because that can have some impact. Hopefully the baby is not late, because that can impact the mum and her discomfort, right? So now we want to look at some postnatal developmental trends for a typically developing human, okay? So overall then, we have this, what they call a sigmoid, or an S-shaped growth curve. So let me draw that. Okay, so, oops, excuse me. So here we have time, and here we have growth. And what we see, the reason it's called an S, is that we get very rapid growth during year 1, and year 2's a little bit slower, but not much slower. Then we have some chugging along type growth, and then we have a very sharp growth spurt during puberty, and then the systems tail off depending which system we're looking at. Okay, so here is puberty. So this is going to occur at a different time depending on whether the baby is a boy or a girl. All right. This is year 1. This is year 2. And then we get this kind of chugging. It's not that we're not growing here, we're just growing usually about the same number of inches and about the same number of pounds every year during this time. So it's a very steady curve here. Okay? So they call it an S curve. Page, did I correct that page last semester? Let's have a look. So that's the universal picture. This S-curve is our universality. All typically developing humans are going to show the increase. So this baby has grown from 1 cell to this 7.5 pound squalling mass that's born, right, in 9 months. That's the most rapid growth you ever see. But in the next 12 months, we also get rapid growth, okay? Kind of continues. So it goes from being helpless, remember our picture where we had the newborn baby, and then the picture at 8, 9 months where the baby's sitting up and playing with toys. Lots of change going on there, okay? But then we have our specificity, our special kind of timing that is very individual, okay? And the timing differs between the sexes, particularly that pubertal spurt starts later for boys than it does for girls, and it goes on a bit longer for boys than it does for girls. Right? And then let me see if it is page 66, because I suspect it isn't page 66 because we have a new edition of the book. Let's see here. Okay, no. It's 166. Okay. So if you go to page 166, figure 8.7 is a very good visual for you to understand how the proportions of the body change across time, across this growth time. All right? And that can be important because when you look at that diagram, look at the proportion of the head to the rest of the body, bless you, for the baby versus the head to the rest of the body for the adult. Okay? So some of the motor patterns that we see when we work with younger children occur because their head is still quite big compared to the rest of their body. And it's just starting, you know, depending which age group you're working with, to get more proportional. Okay? That's the end of that one. Where are we? 10 past. Okay. Let me pull up the next. How many here? I have 12 here. Okay. Ready? Here we go. All right, so we have our S-curve, right? The S-curve applies to most systems, but the systems are developing at different times, okay? So when we look at height, then we're looking at the skeletal system. And for girls, their pubertal spurt can start anywhere from 9 is considered very young, but it does happen occasionally. Usually it's more likely to be around 10, 11, through to about 16, 15, 16, all right? That's the typical age range for girls' puberty. Now, you get people that do different things, right? We get kids start puberty at 8, or we get girls that don't start puberty until they're 14 or 15, right? But the typical pattern is somewhere around 10, 11 for starting, and then around 16 for stopping, okay? So during that age range, then, for a girl, her peak height velocity, so this is the point in time when her skeleton is growing the fastest, okay? Usually occurs around 11.5 to 12, all right? And then her growth in height tapers off from about 14. So by 14, on average, she's not going to grow very much more between 14 and 16. Right? There'll be a little bit, but not a lot. Okay? So, for boys, we have a different picture. They go into puberty around 11.5 to 12.5, 13, right? And their peak height velocity goes from is occurring around 13.5 to 14 years. Their growth in height continues until they're 17 and then starts to taper off until around 18. So there's a couple of interesting things here, right? One of the reasons that men on average are taller than women is that genetically they get a longer growth spurt for their skeleton than women do, right? So that's a sexual difference. Not always, right? We know that really great volleyball and basketball female players are this big, right? But they're not average, okay? We also know gymnasts and other women who are this big, right? They're not average either, right? So we're talking an average picture here, right? And individuals can obviously differ from the average. My younger brother, he's 35 now, I think. I lose track. He's fixed at 17 in my brain. He went to college and he was still growing when he graduated at 21. So he was very atypical from a height perspective, right? One of the other, let me just check the next slide. I don't think this info is on the next slide now. So another thing to pay attention to for your daughters or your girls in your classroom is that peak height velocity during puberty for girls occurs about a year before they start menstruating. So that can be a useful tool to use because if you're measuring their height on a regular basis, either in class as an interesting project, or if you're the parent at home, right, we probably all could go into our childhood homes and find those pencil marks on the wall where mum or dad measured us off, right? If you're keeping track of that, and she has started this rapid period of growth in height, then you can start getting her mentally prepared for what's coming in about a year, 10 to 12 months later, right? Which can be important because it's a little traumatic if you're not expecting it, right? The boys wouldn't understand. I'm sure the girls listening understand, right? So when we look at a velocity curve rather than a growth curve, a velocity curve looks like this. So quite different to the S-shaped curve, but it's really giving us the same information, just in a different format. Okay? So here we have age or time, and here we have, instead of growth, we have gain. Okay? So obviously the baby doesn't get smaller over the first few years, right? This is the fact that we had the sharp growth spurt between birth and 1, 1.5, 2, and from 2 or so onwards we get this very steady change, and then suddenly we hit puberty. So when we look at a change from a flat or a slight down to a sudden up, that's the beginning of the growth spurt. Okay? Here's the girl's peak height velocity. So about a year from here, she's going to start menstruating. And after peak height velocity, she's still growing, but she's growing more slowly. Same picture for the boys, but later. All right? Girls are physiologically more mature than boys at most points. Right? Okay, so then when we look at weight instead of height, we would typically still expect an S-curve, but weight is related to some other systems, right? So we've got the development of the muscular system, we have the development of the adipose system, we also have some bone density, so the skeleton is growing up, but it's also got to put on weight in the skeleton. So weight should follow this S-curve, but it's much more variable because it's so much more susceptible to environmental factors, all right? So if the child does average amount of physical activity and they eat a healthy amount of calories, then we would see a typical S-curve. If the child is undernourished, which we see a lot in New Mexico, then they may be very underweight for their age. Okay, they're not developing enough muscle mass and they're not developing enough adipose tissue. That could be, they could be getting some physical activity, but they're not getting enough calories to fuel that activity and fuel growth, right? When we look back to our pubertal peak height velocity idea, right? Peak weight velocity comes after peak height velocity. So when we watch children who go into puberty, they grow up and then they start to fill out, particularly boys. Right? Boys do this massive, very rapid change in height, and they get real clumsy for a while because it takes a while for the muscular system to catch up to be able to move this massively bigger skeleton that it now has, right? So imagine that, you're pre-puberty and your hand is here and your brain's learned all this skill set with the hand about here, and then you go into puberty and all of a sudden your hand is out here, And it weighs a ton, and you don't have the muscle mass yet to manage that extra weight and extra length of the arm or the leg, right? So we see some quite clumsy behaviors in pubertal boys, early teenage boys, because it takes a while for the muscular system to catch up and manage that skeleton, okay? All right, 12, how many have I done? 1, 2, 3, 4. Let's do this one as well, and then, yes, we'll stop there. Okay. So, when we come back to the idea of the skeleton, we were initially looking at changes in height. All right, so that's leg length, that's the length of the trunk and the spine, okay? But we also have some other growth spurts that occur before the muscle is laid on top of this skeleton, okay? So for boys, after they've gone through their peak height velocity, they go through what we call a biacromial spurt. So the acromion processes are those lumps you can feel, right, at the end of your collarbone, right? So what we get is shoot up this way, and then their shoulders get broader, right? So if you've got young males in your family, cousins or siblings, watch them, right? You'll see it happen. They go dum, dum, right? So then after they've done their biacromial growth spurt, so they're getting this triangular shape, then we start to see an increase in growth of muscle, and muscle mass then increases, and they start to put on muscle across their chest, their shoulders, their upper back. Okay. For females, for the girls, they have a different growth spurt. So after they've done their peak height velocity, then typically most girls are going to have a biiliac growth spurt. So the iliac crests are those bones you can feel poking out at the front here. So the girls do this and then this, right? The upside down of the boys, okay? They don't undergo the biacromial spurt at all, okay? So that's an interesting thing to keep an eye on if you're going to be a PE teacher and you're going to work with kids who might be going through puberty. Because when the girls' hips get wider, when this biiliac growth spurt occurs, it changes the angle of the femur into the knee, right? That's called the Q angle, okay? So as the hips get bigger, the femurs do this, right? Because the head of the femur is stuck in the hip joint, okay? So it's not the only reason that female athletes have more knee injuries than male athletes, but it's one of the factors that plays a role is the change in Q angle. It's also one of the reasons you see, if you watch any kind of athletics and you watch the distance runners, you rarely will see a good quality female distance runner who has great big hips, right? They're all tiny. They've all got quite male looking bodies, right? Their biiliac growth spurt was relatively small because otherwise they can't put in the miles it takes to be a world-class 10K runner or a world-class marathon runner. If their Q angle is really strong, they're going to have knee injuries all the time and hip injuries all the time, right? So the people that turn up at World Championships or Olympics, these women are all quite narrow-hipped, typically, not all, right? You're always going to get someone that isn't, but typically, okay? So this change in the skeleton can impact injuries, can impact motor skill development, can impact enjoyment, right? It's also why guys are much more muscly than women in their upper body because they've got a bigger skeleton to pour all this muscle onto. And girls are more muscular here and here because they've got a little bit more skeleton to put it onto. When we look at the discrepancy in strength between men and women, much bigger discrepancy in the upper body than there is in the lower body, right? Some women who are strong can hold their own with some guys who are quite weak, right? Girls have very strong legs, butts, hips. Guys have very strong chests and backs and shoulders, right? Okay, so I think I will stop there for today. All right, you've got a little bit of time to go back and review some of this information. All right, and then on, what day is it today? Thursday. Next Tuesday, we will finish a little bit of information about some other systems, and we will start chapter 9, I believe. Okay. Anybody got any other questions on what we've covered today?
I do have a question.
Sure.
Not about what we covered today, but about the assignments.
Okay.
So I wanted to just make sure that as per now, we did not have to do anything more than the pre-chapter quizzes.
In class,
Yes.
I believe that is correct. I think you've got pre-chapter quizzes and exam 1 before there's an assignment on the syllabus. Let me double check that I'm not telling you fibs here. Okay. Schedule. Yeah, pre-chapter quizzes and the exam, and then it's not until the week of midterms that there's another type of assignment due.
Okay, cool. Thank you so much.
Okay? Anything else I can help with today? Okay, tomorrow, because I missed Wednesday, I've changed up the